vast teaching experience and has given many publications and presentations. Dr. Suman, for a sound approach to fibroids versus adenomyosis.
Thank you, Ram Raju, for giving me this opportunity. At the same time, I feel a little scared. I'm a single radiologist, 100 gynecologists, very hungry, waiting for the lunch. Just give me 10 minutes and I'll be off from this. Most of my work has already been done by Ram Raju. He's already told you about the endomyometrial junction, the junctional zone. So this is an extension of his talk. As we progressed on the imaging in the last decade, and we have been using more of MRI for imaging of gynecological disorders, we started learning that how much we have missed adenomyosis in the last 1 decade. So essentially that's the part of my lecture today. So I'll be showing you simultaneously the ultrasound and MRI images so that you get a better understanding and also see how different both of them would be and which would be better. Now you have a sagittal scan of a uterus here. You can see the endometrial lining here. And this black line which is around this endometrium, this is the junctional zone. And this is the outer myometrium. Okay? And you see a sagittal section of the uterus in a T2 weighted images in MRI. You see the nice endometrium here. And this is the junctional zone, which is more hypo-intense or black compared to the outer myometrium here. And this is the way we measure the distance. We take the distance of in a perpendicular manner, and the normal junctional zone should be less than 8 millimeters in a normal individual, and whenever it's more than 12, we call it as adenomyosis, and 8 to 12 is a gray area where we have to take in other features into account. So let me just show you fibroids, or one thing which we confuse most with adenomyosis. And previously we used to pass on many uteruses, diffusely enlarged uterus with heterogeneous echogenicity, probably multiple fibroids, but most of them are now turning out to be adenomyosis. A fibroid is something which is a proliferation of smooth muscle and connective tissue, as you all know. It has a pseudocapsule, very well encapsulated, and on a cut section has a whorled appearance. And if you see an MRI here, the same features are there. It's a very well-defined nodular mass here, and has a. I'll show in the next sections also. Let's see how adenomyosis looks, where there is heterotopic endometrial glands and stroma which go from the basal endometrium into the myometrium, and these glands can dilate and also have hemorrhage within them, and these are the ones, the features or the ones which are going to see in the imaging. So in ultrasound, what you see, these glands as echogenic, ill-defined nodular lesions, and they can also be small cystic lesions in the subendometrial layer. On an MRI, what we see them on T2 weighted images is a bright fluid containing foci, and if they contain blood within them, we see them bright on T1 weighted images. So whenever these glands go and proliferate, the smooth muscle also tries to compensate and have an hyperplasia around them, and these are seen as focal areas of decreased echogenicity around them. Even on MRI, we see low density or low signal intensity areas. And you can see here the adenomyotic focal adenomyosis here. There's increased thickness of the junctional zone. This is a normal one here, and this is a thickened zone. And you can see the small cystic areas and patchy areas of hypointensity. And this is a generalized thickening in this image. So I don't have to go back into this. You all know these types of fibroids, and they're based on their location. And I just wanted to show you that most of the fibroids are well defined, and they're hypoechoic compared to the rest of the myometrium. And most often they produce a contour abnormality. When they're close to the endometrium, they press on the endometrium. And when they're towards the serosal surface, they produce a contour abnormality. This is the characteristic of fibroids. I would always prefer an MRI. And unusual locations like a cervical fibroid or an extrauterine fibroid or a intracavitary fibroids, definitely MRI would score over them. And whenever you have a complication in a fibroid, MR would definitely show you whether there's a degeneration in a fibroid, if there is a bleed inside a fibroid. All this can be picked up and documented on an MRI. And can assess the response to treatment in the newer modalities like uterine artery embolization and MR-guided focused ultrasound, which are coming into vogue now for treatment of this. The MR is the primary modality of seeing these tumors for this response. So as I've told you, this is a broad ligament fibroid. So in these sort of patients, MR would be better. A pedunculated fibroid going into the endometrial canal. You can see this vascular pedicle going along with it. And this is a large fibroid with a heterogeneous echogenicity areas of cystic areas, which in an MR shows better that it's a degenerated fibroid. So how do you see a fibroid in MRI? They're best seen on T2 weighted images, where you see these fibroids as hypo-intense compared to the, or blacker than the normal myometrium. On a T1 weighted images, they are iso-intense or the same intensity as the myometrium. So you do not see them very well on T1 weighted images. So basically T1 weighted images give us two things. One thing is whether the lesion is containing fat or hemorrhage. See, in this patient with a red degeneration of a fibroid, we have a hyperintense signal on T2 weighted images as well or in the T1 weighted images. That shows us that this fibroid has bled inside. So by using these two sequences, we know that there's a hemorrhage within the fibroid. Similarly, as I've already told you, the fibroids cause mass effect over the endometrium. See this submucosal fibroid here causing severe mass effect over the endometrium. And a large fibroid like this, and this is the uterus here, and a large fibroid like this would be very difficult to delineate an ultrasound, and MR would be a much better modality to use. This is a sentiment by Dr. Edward Lyons from Professor of Radiology. I think that adenomyosis is terribly underdiagnosed. Majority of people who come in for pelvic pain, menorrhagia have adenomyosis and is often mistaken for fibroids in clinical practice. This is what we are seeing in the last few years after using MRI, that we have missing a lot of patients of adenomyosis, especially in the early stages. So the role of imaging here is to not only to establish the diagnosis, we can also say whether it's a focal or a diffuse disease, and we can also see the depth of invasion of the adenomyosis and also monitor the disease once you start a medical treatment or other modality of treatments. So I've already told you about the junctional zone. The normal is, we have to remember, it's less than 8 millimeters normal, more than 12 millimeters is adenomyotic. Let us see what are the findings in adenomyosis. Most often what we find is asymmetric enlargement of the uterus. So when one wall of the uterus is thicker than the other one, suspect adenomyosis. Then there's abnormal myometrial echogenicity. If you have a heterogeneous myometrium with small cystic areas or acoustic shadowing from the myometrium, think about adenomyosis. And if you have a subendometrial small cystic areas, which can be seen on MRI as high signal intensity foci, then think about adenomyosis. You can also see small echogenic nodules and striations from the endometrium, which I'll be showing you pictures. And we have something called a pseudo-widening of the endometrium. The endometrial borders become fuzzy, and the endometrium looks actually more thicker than what it is normally. Then it is a case of adenomyosis.